talk today about the Omic experience in terms of the 25-year history of professional liability with our specialty, pediatric ophthalmology and strabismus. Today we're going to be painting more with broad strokes. A lot of these meetings you've attended, we deal with a specific topic or a few cases to highlight a point. Today we're going to be looking at the broad experience. I'm my co-presenter, Ann Minke, who you know, risk manager, and Ann's been with the company 10 years, and I've participated on the underwriting and finance committees for the past 4 years. This is the outline of our talk. We're going to talk about the background, why we did the study, look at the database. You can understand where the results are coming from today and who we included. We'll show you the statistics, and then Ann's going to talk to you about some lessons you can take home from all of this. Well, why do we do this study? Although there are some reports about specific areas of pediatric ophthalmology, for example, there was a report a few years ago on retinopathy of prematurity. There really isn't any report of the comprehensive claim statistics in the medical literature relating to our specialty as a whole. And the other reason for timing it now, 25 years, is a nice round number. Omic just turned 25, so we have a 25-year database. And then what we hope to do with this is have you use these findings for risk management in your own practices and help you improve the quality of care you provide your patients. So again, to understand where these claims are coming from, the database is Omic, formed in 1987 by the American Academy of Ophthalmology. To be insured by Omic, you have to be an Academy member. These insureds are mostly all from private practice, just the nature of the way professional liability insurance is handled. If you're in an academic setting, you're generally going to have your professional liability insurance through the academic institution or hospital system that you're employed by. But Omic is the largest insurer of ophthalmologists, 65% of those currently eligible in private practice. Furthermore, to understand the way the claims are coming in over this 25-year period, you have to understand what Omic's growth itself looks like over that 25 years. And so Omic was a small company back in 1987, 754 insureds, but has grown over the last 25 years to now have 4,500 insureds. And so again, when you're seeing the data, this is highlighted on this slide here, you would expect claims to go up with time as the company gets bigger. And this slide shows that. The blue bars are the number of insureds, and you would expect if there was a perfect correlation between insureds and claims, that red line, which is the number of claims, would directly follow the blue bars up. You can see it does approximately, but in the early 2000s there was a spike in claims, more frequency, we say, during those years. That has fortunately tapered off a little bit in the last few years. So who did we include in this study? We took any claim that was classified as a pediatric ophthalmology claim or one classified as strabismus that closed between the beginning of the company in 1987 to any claim that closed up until March 1st of this year. In pediatric ophthalmology, we defined, as does the AAP, from birth to 21 years of age. So this was a retrospective review of these of the claim summaries and defense counsel case evaluations of all the cases that met the inclusion criteria, and I began to joke to Ann that this was becoming my doctoral thesis as the Omic staff, which was very good, began pushing all of these claim summaries to me, which ranged anywhere from a few pages to some many pages long. And this was the data we collected from those claim summaries. We collected the age of the insured, the coverage level, specialty, gender, what state that ophthalmologist was practicing in, the age of the plaintiff, what was the allegation, what was the clinical category of the claim, where the incident occurred, when did the incident occur, when was the claim opened, when was it closed, did the experts feel the standard of care was breached, the cause of the claim, what were the expense and indemnity payments, and then whether or not the case went to trial or mediation. And these are our results. There were 140 closed claims, 119 against individuals, 21 against entities. And then among these, there were 118 actual cases or plaintiffs. So you can see that means that some plaintiffs went after more than one physician or an entity. And that's how this broke down below. 93 were against one physician, and then the rest were either against multiple physicians or a physician and an entity. Most of what I'm going to talk to you about as we go forward is about the individual claims. I'm going to summarize the entity claims on this slide. There were 21 of these, and most commonly an entity claim arises, it's simply a companion suit to the individual claim. So what does that mean? It means that frequently there's no additional allegations against the entity beyond the doctrine of vicarious liability for the actions of the employee. That is, the organization employs that physician, therefore we can sue the entity or the organization as well. There were 3 indemnity payments, and sometimes the entity itself was held to be separately responsible from the physician. Generally, the entity was either dismissed from the case, or if the physician was held liable, the entity itself was not held liable. But there were a couple of cases, I'll tell you, not to get too far into the weeds, because we're going to try to keep this fairly general today, to show you how an entity claim might come about. In this first one that settled for $1 million, it had to do with an associate physician in the practice being on call for the emergency room calling the associate physician, telling the emergency room, we'll send them to the office in the morning, and the practice will see that patient. Well, the associate physician that took the call wasn't in the office the next day. He was either in another satellite or in surgery or somewhere else. And so the owner physician of the practice found out the patient was there and said, well, we don't see public aid patients, or I don't see public aid patients. But apparently not much effort to get that patient to somewhere. And it turned out the patient had a serious corneal ulcer causing a significant loss of vision. So neither one of the physicians actually saw the patient, and that the entity was held responsible there. The other case for $75,000 was one where an individual physician and an entity were held responsible, and you can see how this would be. This was a case where the wrong eye was operated on in surgery. The wrong eye was draped, and there was no timeout during that procedure, and so both physician and entity were held liable in that case. Now, these are the claims opened by time period. Again, you have to kind of keep in your mind that graph of the growth of Omic to make some sense of this. So you would expect some increase in claims over time, and you do see that happening to a point. This does parallel what was going on in Omic at the time. As remember, in the early 2000s, we were kind of seeing a spike in claims overall, and you see that in that middle 5-year interval. But then they've dropped off some since. The blue are the closed claims. Remember, those are the ones we're really dealing with in this study. I did want to show you the open claims to show you claims haven't dropped off tremendously. They just haven't closed yet at this point. And here are the entities. The entities really haven't gotten involved in all of this until the 1998 to 2002 period, and have remained fairly stable since that time. So these were the insured characteristics, 100 males, 19 females, and This is where they came from, most from Texas, Illinois, Louisiana, and California. And these were the specialties of those involved. Most were pediatric ophthalmologists, followed by comprehensive ophthalmologists, and followed by retinal specialists. And this is the coverage level of the insureds. About 80% are covered at the 1 million, 3 million level. And just to remind you, that means $1 million for a single episode would be your coverage limit in a single year. And the annual aggregate would be that second number, $3 million. So if you had more than one case, you'd be covered up to the level of $3 million. So that's the most common level of coverage. It's also the most common level of coverage in Omic as a whole among all insureds. Second largest category in yellow was the 2 million to 4 million level of coverage, 21%, followed by the higher level, 2 million, 6 million at 3%, and the 5 million to 10 million level of coverage at 2%. Those other ones there that are fairly small numbers are generally ophthalmologists who have separate professional liability coverage through their state. So parts covered through Omic and then parts covered through their state. They pay into a separate fund. And this was the insured age at the time of the incident. You can see it's in the peak years of practice, 35 to 55. I've got about another year before I was looking, my own risks drops off some. Glad to be in that group. Mean age of 45. And here was the plaintiff age at the time of the incident. Most of the plaintiffs are less than a year of age. You see the bulk, of course, it's our specialty, are in the pediatric age years. All of those, by definition, that are older than 21 are adult strabismus case. And where was the location of the incident? Most occurred in the office, followed by the hospital inpatient setting. And what was the clinical category of the claim? Most were strabismus cases, followed by retinopathy of prematurity, trauma, neuropediatric claims, and so forth. And here were the allegations lumped into large categories. The majority were related to treatment in some way. That is, presumably the diagnosis was correct, but there was some problem with treatment. 37 were related in some way to surgery, and 33 diagnosis related, typically failure to diagnose. And this is what happened in terms of the disposition. The bulk, and I think one of our fears as a physician is these cases going to trial, your name being in the paper and drugged through the mud. Well, at least this slide is somewhat reassuring. If anything I say is reassuring, it's that only 7 cases went to trial. The bulk, there was no trial or mediation, and so those cases were either dismissed or they were settled. And then 5 went to mediation or arbitration. And here's the time from the incident to the time of an open claim. The mean is 2.24 years, with a minimum being it's almost instantaneous. Within minutes of the incident, the claim is filed to a maximum. Unfortunately, that's our problem in pediatric ophthalmology, is many times a claim can be filed many years after you've completely forgotten the case, up to 18 years here. And then here's the time from the claim is open to when it's closed. And I think here again is some useful information to keep in mind if you have the misfortune to have a claim filed, as many of us will. The time from it's open to the time it's closed is 2.58 years. So just can't say relax, but you can say at least know it's going to be a process working through this. The minimum, again, there were some cases that were dismissed almost immediately after they were filed, and they unfortunately can go on as long as 11 years, almost 12 years. And these were the results of whether or not the standard of care was breached. Anytime a claim comes to Omic, if it's there long enough, and again, those 13 at the bottom were just not there long enough, they might have been dismissed in very short order. In 62 of those claims, expert review, and that's each claim is reviewed by someone on the claims committee, one or more people from Omic. Usually more than one person will review the claim. And then that claim, if it's going further, will also be reviewed by experts outside of the organization. And so in 62 of those claims, everyone agreed there was no breach of the standard of care in those cases. In 33 cases, there was a general consensus that there was a breach of the standard of care. It was mixed, some yes, some no, and in 11 cases. And now these are the expenses. Whether or not an indemnity payment is made to the plaintiff, most cases are going to have expenses associated with them for the expert witnesses, for the attorneys to defend this claim. 89% of the claims had some payment associated with them, a mean of about $64,000 for these cases for attorney and expert witness expenses, ranging to a maximum of nearly $500,000. And these are the indemnity payments. 35% of the overall claims, if you look at the claims as a whole, had an indemnity payment associated with them, about 30% if you look at the cases themselves. The mean was $473,000. Ann's going to later kind of help you put this in perspective for where that fits in the overall scheme at Omic.
$120,000 is the average claim. So pediatrics is significantly higher in terms of the how many close. So usually about 20-21% of overall claims close with an indemnity payment, and I think our average payment is about $120,000. So you have the privilege of being at the top of your game. So much higher, and for obvious reasons. Young children, lifelong expenses for vision care.
And the maximum ran up to $3,375,000, and correct me if I'm wrong, I think that is also the high at Omic for any single indemnity payment. Great question. I meant to say that, but you reminded me to say it. In no case did the indemnity payment exceed the insured's level of coverage. For any of these cases, and I've asked the question for Omic as a whole, the entire 25-year experience, there has never been an indemnity payment as high as they get that has exceeded the level of coverage. And that's something maybe Ann might address later on. There's sometimes you see we'll take the limits of that insured's coverage, and so there's a kind of a balancing point between does taking more help out or not.
That particular physician had a limit of $5 million, and so we were happy to get it down to 3.375. But it's one of the first questions the plaintiff attorney will ask, and they are allowed to ask it. It is discoverable. Is how much insurance do you have? And we'll take this one question, and then we would rather wait on questions. Do you mind, John, or do you want to ask it now? Okay.
The mean for pediatrics is 470. The mean for Omic as a whole organization is 120. So our severity is higher than the rest of the organization.
And we're hoping to leave time at the end for questions, but if you don't mind waiting, that would work out better.
So these are the cases that had indemnity payments of $1 million or more among the individual cases. Remember, we had the one on the entity side I discussed with you. Leading the pack, retinopathy of prematurity, a case of pseudophakic glaucoma, optic nerve glioma, refractive surgery, and then one patient had a stroke immediately following an adjustment for strabismus surgery. One thing that kind of stood out to me as I looked at this list, there's often not a correlation between, as you read the case, what you think the payment might be and what it turns out to be. The refractive surgery case is one where the patient had an implant placed, had a postoperative rise in pressure, and the only permanent deficit that I could see was a dilated irregular pupil after the case, and that settled for $1 million.
It was a plaintiff verdict. We thought we would win. We took it to court and had a very big surprise. That's a different kind of refractive surprise than they usually talk about at ASCRS.
I'm going to turn over to Ann now.
If you came in late, please make sure you pick up a yellow form. I have a lot of them at the back on chairs and also some here, and then just make sure I get that at the end. So first I want to thank Bob for undertaking this enormous study, and we both want to thank my assistant Linda Nakamura. Jim Sprague and I presented several years ago on Omic's claims experience for pediatric ophthalmology and strabismus, and we located claims by diagnoses. We tried to find it different ways. Well, we did it the hard way this time. I started out doing it, and after about 25 cases, I thought, why do I have an assistant? This is why. So Linda Nakamura actually went into every claim that we've had to find the age of the plaintiff, so we're really sure about these numbers. So just again to give you some placement of these overall, these aren't the whole 25-year history, but it's sort of a rolling 5-year. Cataract leads the pack, which makes perfect sense. It's the most frequently performed surgical procedure in the United States and probably in the world. So just by frequency alone, you're going to get enough patients suing after that. But you can see that the second column shows that cataract is on the rise for some reason. I did a study a couple of years ago about multifocal so-called premium IOLs, and while we certainly get many, many calls every day about this on the risk management hotline, we haven't really seen a big uptick in claims, and we haven't seen a lot of claims being paid out. But certainly those are very demanding patients, those who have the premium IOL. So I'm not really sure what's behind this uptick in cataract, but we're seeing it. Comprehensive ophthalmology, retina, but you see way down the line is pediatrics. So this is frequency. So frequency is, I'm not very good at this little wobbling. There we go. How many claims are filed? But what we talked about that's so different about pediatric ophthalmology and strabismus is something in the business we called severity. So how many of the cases that are brought out do we have to pay to close them? And it's quite a lot, and we close them for quite a lot more money than in other ones. So here's the specialty slide, and you'll notice pediatrics isn't on here because Mary Kasher, who's our VP of claims, says it just ruins her slides. She doesn't put it on because it's so skewed. The numbers are so high, the dollar amounts in pediatric, that it throws everything else off. So I'll show you pediatrics in a second, but this is non-pediatric cornea. Look at that severity jump just last year. But you know, retina, cataract, glaucoma always tends to bring in a lot of payments as well. But here's pediatric severity, and pretty high, and most of these, actually 6 of our top 10 overall claims at Omic are pediatric ophthalmology and strabismus. So 5 of those 6 are pediatric. 1 was that CVA after strabismus surgery. So, you know, just one of the things I should say, I'm going to back up. Whoops. Oh, can I go back? Back one more, please. Is that you cannot judge the severity of the malpractice by the amount of the money paid. I mentioned briefly from the sidelines there that, you know, if you end up going before a jury and you come in with a bilaterally blind baby, they are obviously going to be enormously sympathetic to that plaintiff right from the beginning. Also, there are a lot of costs that are going to be extra in lifelong low vision aids, vocational rehabilitation. And it's something that actually gets contested pretty fiercely, because despite what the family looks like, they're all going to claim that their son or daughter was the next genius, the next president of the United States, because they're going to be claiming lost income, even for a child. And so there's a lot of analysis that goes into that, and both sides have to have economic experts to try and figure out how much it's worth. But it's because of, if you're retired and you lose vision in one eye, you've not lost income, you don't necessarily need a lot of extra care, you can still take care of yourself. So pediatric cases are just going to be more expensive. It doesn't mean that pediatric ophthalmologists are more negligent or have more problems in care. So you really can't draw any conclusions from the amount of money other than kids are more expensive and more sympathetic. So I'm going to look at some of the things, obviously our goal here is we wanted to get some data, but also what can you do differently, what should you be doing differently in your own practice. So I tried to aggregate this into lessons learned. So my first of two categories is going to be what I call costly conditions. So these are ones where there's a high likelihood where not only will you be sued, but you're going to have to pay to close the case. And so what can you do to make this less likely to happen to you? So one of them is going to be, when you see this particular category, consider longer appointment times. Really important to have patient education materials in addition to informed consent documents. Obviously, strabismus surgery, we're going to be talking a lot about that, but very, very explicit goal setting and prognosis management, but not just that, also in the cataract cases we saw, where there was confusion about whether an IOL would be implanted or not, and why or why not. Glaucoma cases where it wasn't clear why you would choose medical versus surgical management. So you really have to make sure that the parents and you have very explicit goal-setting discussions. I'm saying this in the context of knowing the pressures facing you in your offices and knowing how very little time you have per patient. So I'm going to be giving you lots of recommendations. That's what they pay me for. But if you're not sure which ones to implement, which are the higher risk things, call the risk manager of whoever insures you to do a practice analysis. And we can work with you and say, okay, tell me what you do in the office, what kinds of surgeries, and pretty quickly I can tell you based on claims data where your riskiest patients are going to be and what you can do to reduce that risk. So I'm going to give a lot of recommendations. I know that except for my board members, you're not going to be able to implement all these. Now, I've argued most of these with my board members. Nobody can do everything. That's why you have to have some risk stratification and decide what you can do. By the way, besides Bob Wiggins, you are well represented. Bob Gold is here, who's on the Omic board, and Denise Chambly. So we currently have 3 Aapos members on the Omic board, which is a very high number. So I didn't quite do a top 10 David Letterman, but I did the top 7 backwards. So adult strabismus. 19% of our claims were for adult strabismus, and we had to pay 27% of those cases to close them. And again, Omic's average is about 20, 21% to close. Biggest lesson, informed consent. We have a sample strabismus consent form on our website, which is an open access website. Whether you're with Omic or not, you may access anything on there. You have to clarify your goal and expectations. Jim Sprague and I gave a talk just on adult strabismus a couple of years ago, and I presented a case to the practice administrators where even with that, what we consider to be outstanding informed consent, there was a tremendous disconnect between what the patient heard and thought was the goal of the surgery and what the strabismus specialist. So he was thrilled with the outcome, felt he got exactly what he had planned on, but it turns out that wasn't at all what the patient after the outcome said that he wanted. So it's really important. Now, I put this adult strabismus support group. In my field of healthcare risk management, the big push now is something called e-patients. So patients who are either looking up information on the internet, and may they please look at Aapos and AAO websites, but also talking to one another. So if you have patients who have successfully navigated adult strabismus surgery, or families who have had their kids go through strabismus surgery and can get them to talk to one another, it would help enormously to set realistic expectations. So it's just a suggestion I'm making. And I think it's something Aapos as a body might want to explore, whether you want to sponsor some kind of support group online. I think it would make a very big difference, because this group of patients in particular is really challenged They've often had childhood strabismus, prior surgeries, their scar tissue. They suddenly think they're going to look great. Their expectations are really not realistic at all, despite your very, very, very good effort. So I think you can't do it on your own, and so I'm encouraging you to elicit the support of others. Trauma. This was 14% of the claims, and 31% of the cases ended up having to be paid. And I can stand up here, I'm not an ophthalmologist, and it's going to seem very, very obvious, but you really do have to rule out foreign bodies. ER patients, this was a big risk category where you're the doctor on call and you're speaking to an ER physician, and unless you really know that physician well, you have to have a very low threshold for going in and examining the patient personally. We have after-hour forms that I'll talk about again a little bit later, but you want to make sure you're asking enough questions explicitly. Did you use a slit lamp exam? What kind of injury was it? What was the mechanism of the injury? Because, sad to say, but you can't necessarily rely on what the ER physician tells you, and you are held to the higher standard of care because you're a subspecialist. So if you don't drive that conversation and get the right information, and better information would have convinced you to go in and see the patient, then you are the one who's going to be held liable. Infection, ulcer, and fracture, you really have to be very mindful of those. I talked to my risk management committee, because we now in risk management are very fond of checklists. And by the way, Omic was the one who got the ball rolling on the ophthalmic-specific surgical checklist. I hope you're all using it. But I asked about, would it be helpful to have a trauma checklist? And you'll be glad to know you won't have to use one. I got shot down very quickly. But it turns out one of our board members, Ron Pelton, updated our current chairman of the board, John Shore, had written the focal points on management of orbital trauma and was recently updated by Ron Pelton. It's a great document. The Academy does make you pay for it, but I think it's really worthwhile. So number 5, cataract. So very infrequent, only 6%, and obviously these are not, no p-values given here. These are not statistically significant. These are just based on our numbers. But as I mentioned earlier, why are you doing surgery versus non-surgical care, whether you're going to use an IOL or glasses, infection, and careful handoff. One of the cases we had, which had a very severe endophthalmitis, there wasn't a good handoff. Apparently the person who was covering for our ophthalmologist was not as familiar with what to watch for, wasn't worried, didn't ask about how recently surgery had happened. And again, on our after-hours contact form, you need to, if somebody's calling you after hours, a parent, you need to find out, because if you heard the child had just had cataract surgery and has a red, a painful eye, you might be a little bit more nervous. I would hope you'd be a little bit more nervous about that call. Number 4, cornea. 10% of our claims were cornea, which, you know, these kids are out there, they're falling down, they're doing all kinds of interesting things, but it was a high-risk area. A third of the cases ended up having a payment. Infection, there was a lot of problems with diagnosis in this, so confirming the etiology of the infection. And here's where, if you're not a cornea expert, consider early referral, because there is absolutely no liability exposure for referring, but there's a lot for failure to refer. So if you hold on to a child and monitor this corneal condition longer than you should have retrospectively, you're going to be held to the standard of a corneal specialist. You're sort of substituting yourself for a corneal specialist. So consider kids who aren't, eyes that aren't responding, symptoms that are progressing, patients who are calling a lot, any of those signs of a misdiagnosis, consider getting a consult. Ulcer was a really big problem, and Bob had mentioned this in his analysis as well. Obviously, before you put somebody on steroids for an ulcer, you want to rule out infection, especially Pseudomonas. Very careful follow-up. We're going to talk about follow-up later. There was a great discussion in the pediatric glaucoma session yesterday about the problems of follow-up. And again, early referral. The third was neuro-ophthalmology. 9% of the cases, 36% of those ended up in payment. Differential diagnosis. I mean, I sat in on a couple of the neuro workshops, and you know, it's really hard to make the correct diagnosis on these. There are a lot of masqueraders. There's a lot of, sometimes it just takes a while for a disease to declare itself. But if you don't communicate and document your differential diagnosis from the beginning, it's going to be very hard to support your care, and that's often what we find, is that there was no differential diagnosis. Meticulous follow-up with kids who have a possible neuro problem. Schedule the appointment yourself. Make sure that the consultant saw the patient, that you got the report back, that you followed up on the report. A lot of these neuro cases were kids who were lost to follow-up, and as I say every time I come here, whether you like it or not, the courts do hold you responsible for following up on non-compliant patients. Tracking test results, same thing as tracking consultations, crucial. Why bother to send someone out for a test if you're not going to make sure you get the results back? And you want to train your staff on which tests and consultations are really high risk so that they're watching those for you. And again, later I'll talk about a system for tracking those. The consultations, I know it's a lot of work. I really do appreciate what you're up against. But again, who's your high-risk patient? And on high-risk patients, schedule that appointment yourself. You can't, the parents are notoriously unreliable. And if you at least didn't make sure they went for the appointment, you're going to be held liable for failure to follow up. But it's just a lot less trouble, believe me, to schedule it yourself, track whether they went, and really be on them. Did I skip one? Could I go back, please? No, never mind. I can't count backwards. ROP, obviously, but you notice it's not the top one. So 47% of our ROP cases end up in an indemnity payment, and there's 16% of our claims. We've learned the hard way, and our ROP safety net is based on our experience, and so it's available. I'm happy to help hospitals, whether they're anybody who needs help with ROP, please call me. But we have found that it really is like rocket science. It's sort of like preventing wrong events. It really is hard to keep track of these kids, and so we require triple tracking: somebody at the hospital, somebody in the office, and the ophthalmologist. And so each week you're reconciling those lists so that no kids fall through the cracks, because it's really amazing the number of ways a baby can fall through the cracks. The other thing is we found out that there is a lack of current knowledge in some of the cases, and that's why I bothered to type up all the current protocols so that you have them at the point of care. It was hard to get copyright permission from all the different studies, so I just type up the latest ones, put them in the document, the safety net, and you have them there in your NICU and in your office, so you're not trying to remember what's the follow-up period here, or when is the end of screening criteria, or when do I start screening. So it's all the criteria right there at point of care. Obviously, it does help us a lot if you know the natural history of the disease, and I'm sure you've heard, if you've been tracking the work on Avastin for ROP, that it changes the natural history of the disease, and you have to know that and track those babies differently, both in terms of frequency and how long you follow them up, if you want to keep them seeing and keep yourselves out of court. The number one, pediatric strabismus. 14% of our claims database, half of these ended in payment, half of the pediatric cases. Well, some of it is not your fault. The people who were causing problems are not here. So we found a tremendous willingness among comprehensive ophthalmologists to take on really complex strabismus cases. And so if you know any comprehensive ophthalmologists in your community, you can tell them that if they want half of every case, half their cases to end up in lawsuits, continue, otherwise send them to you. Decision-making process, really important to document it. It's not so much important as what you decide as if somebody who comes back later and reviews your record can understand what your decision was. Really clear both in pediatric and adult to make it clear from the beginning that it's very likely that there might be another surgery required. It's always a good idea to perform the intended surgery. John Simon was here and did that great study on wrong cases, wrong patient, wrong eye, wrong muscle. We had a lot of wrong cases in the pediatric strabismus group, and you just don't want that to happen. There are really good guidelines about that I'll be referring to later. And then manage amblyopia in the setting of pediatric strabismus. The second thing I wanted to talk about are what I called vulnerabilities. So these are processes that lead to patient harm and cause significant payments if they're not managed well, but also these are areas where if you're going to make some changes, here are the ones I'm recommending in decreasing order of importance, or I guess increasing. One of those, 50-50. Wrong events, the total we paid on this, $210,000. We had 3 wrong eye. and 2 wrong muscle, which I imagine is a little easier to do. The ophthalmic surgery checklist, which is on our website among other websites, has a really good protocol for this. There's also the task force that the Academy, Aapos, and Omic were members of, and their task force report is on your website as well as ours. It really is hard. It turns out it's especially hard to get the right eye at the ASC or the hospital if your office sends the wrong information. You can do timeouts till you're blue in the face. If you send the wrong information, if you got it wrong in the office, it's not going to help. And that's one of the surprises from John Simon's study, was how many of the wrong cases actually happened in the office, not in the OR. Every procedure, every setting, every team, you need to make sure that you're doing the right one. And as you heard, I don't know that it's come to ophthalmology yet, but CMS, Centers for Medicare and Medicaid Services, is starting to not pay if you make certain kinds of mistakes, and it's just a matter of time before this is going to be added, because they're considered never events. Even though they're actually quite hard to prevent, they're ones that there's not a lot of tolerance for these errors in the community and now in the payers, so something to really pay attention to. The 5th one, informed consent. 15% of the cases, we totaled $280,000, and what I mean by this is everything else about the case was, the care was very, very good. It was just the informed consent process that could not be defended. So your best bet is procedure-specific consent forms. Again, they are free on our website. Educational materials so that people go home and can read more about it. And again, strabismus and amblyopia, I would really consider Aapos finding some support groups, or you finding your own support groups among your own patient population, as it does help patients have realistic expectations. The cases that this was really a problem in were strabismus and cataract, and as I mentioned earlier, you have to explicitly agree on your interim and long-term goals, and then any limits on success. We had some refractive surgery cases, which probably none of you do refractive surgery, although I found that paper this morning very interesting, about developmentally challenged kids, where that might be the right thing to do. But if you have to tell the patient or the parent, in this case, if you're not going to treat astigmatism. So their informed consent has to be about what you are going to treat and what you're not going to treat. So we've had a number of cases where it wasn't explicit what the limits of the treatment were, or if there were comorbidities that were going to limit the effectiveness of the surgery. You want to make that very clear. So here are some pointers about the informed consent process. So cultivate the relationship. What do you think, talking to the patient, what do you think is wrong? What bothers you the most? How do you use your eyes? This turns out to be really important, not just in refractive surgery cases, but in adult strabismus. What do you feel should be done and when, and what's your goal? Cultivate understanding. What do you think caused this, especially if it's coming back? What do you think is making it come back? How was it corrected the first time? We had a number of cases where the patient thought the same technique should have been used the second surgery and wasn't, and was very upset and sued about this. So if it's going to be different, you might take the time to explain that. How will the surgery help? What won't it help? What complications might happen? And will you need more than one surgery? Really key. Resiliency is something that I think is really important to think about, because some people have it naturally. They have just had really hard lives, and yet they just are able, ever-ready bunny, keep bouncing back. And other people, you look at them and you think, well, gosh, that hangnail, really? You're going to, So people have different levels, but you can cultivate this. You can help patients. And one of the things that I wanted to mention in the pediatric glaucoma session yesterday was prepare patients to be non-compliant. And by that I don't mean encourage it, but let them know that people have trouble taking these drops, or we often find out people don't take their drops because they don't think they have the disease, or they don't have the money, or sort of say, if you have problems, let us know, but many people do. So here, diplopia was one of the big drivers of the strabismus claim, so asking people, many people have this for a while. How will this impact your work and life if you have double vision for a while? If you need more than one operation, how will you feel about that? And again, you don't want anybody to be surprised, so you're planting the idea in their head that, oh, I might have double vision. Well, that's going to be really hard, so I think I'll talk to my boss about if this comes up, I'll need some extra time off. The surgery may not correct all of your symptoms. How disappointed will you be, and will the surgery seem worthwhile? Now, again, I'm very aware of the limited time you have, but just even planting these ideas and helping patients decide, okay, am I willing to risk this? You know, am I willing to go through with it if I may have another surgery, may have diplopia? We had a case where, you know, this patient felt like he was actually much better off before his surgery. Really important question. If you don't understand or are uncomfortable, will you talk to us about it? Because a lot of times you find out what the problem was during discovery, during litigation. So, and defensibility, communicate and document. I think we've talked about that enough. Give a procedure-specific consent form, and ours sample does go over all these issues. And then there's good old risk avoidance. You should have your entire team helping you sort of identify patients who are really never going to be happy. And if they're troublesome from the word go, or really sweet to you and your staff say they're really nasty to them, I would really, you know, it's one of the few places you have any power in medicine today. You are not required to continue treating someone unless your contract says you have to, or you'd want to be really careful with anybody covered under Americans with Disabilities Act. But, you know, send them to someone else, you know. So I think you want patients to be satisfied, and if you get the sense before surgery and it's not an emergency procedure, let somebody else handle them. Telephone care, 6% of claims, almost $500,000. We do have a screening document for your staff to use that prompts questions to ask and then to assign a category. And then there's also the after-hour form. I think there's my only visual for those of you who are not verbal. That's the after-hours on-call contact form. I've often been asked about what about texting and emailing. You know, texting is not very helpful about anything because it's really hard to document the date and time and put that into a record. Emails aren't bad, but even Post-it notes or napkins here at the conference that you then paste into the record if you're still one of those majority of ophthalmologists not doing EMR. But you want something that prompts you. That case that Dr. Wiggins talked about, the physician was at the movies the night before leaving for vacation. So he didn't document the phone call. He forgot to tell his office he was sending the patient to them. But if you had a form like this, you fax it to them and they know what to expect. So use the contact form. Oh, we mentioned already about ER exams was a really high-risk area. Low threshold for seeing post-op patients or ER patients. If you have a patient in the ER that you're comfortable sending orders in and not seeing the patient, but they're complicated, fax the orders in so that there's no question about what you're recommending. This is one where it's really hard to figure out. There were a couple of really nice posters looking at the diagnostic process, and it's really hard. As I think Bob showed that a third of the cases, if not more, are diagnosis related. So here, 13% of them, over $1.5 million paid. Obviously preferred practice patterns, clinical guidelines, again, at the point of care. I told you our trauma checklist was, got the X, but the corneal infection ulcer checklist is in development, so that may be coming your way soon. Here's the real important takeaway point is that a misdiagnosis, and this is overall in medicine, not specific to Omic's database, but only 4% of the time was it because of inadequate skill or knowledge. And most of it is it's your thinking process. It's not what might be buried very deep in there in that brain of yours, but the actual way you go about diagnosing. So if you don't get good data, bad data in, bad data out, so if you're not asking good questions, and shortcuts, ways of sort of closing down the diagnostic process too soon. And here are some of the types. I've written some articles about this. If you're interested, you can email me. I can send that to you. But so what are the signs you might have missed a diagnosis? The findings are unexpected. The condition's not responding to treatment. It doesn't account for all the findings. And sometimes that's okay if the findings are not very worrisome, but you should at least be looking at that. Does this account for everything I'm seeing? Often what happens is that there was a comorbidity that the ophthalmologist sort of seized upon and early on decided that's what the problem is and didn't fully develop a differential diagnosis. And multiple patient visits, especially for a worsening condition. So cognitive strategies, pause and ask yourself what else could be producing this. This is going to prompt you to develop a differential diagnosis. And worst case scenario, if I'm wrong, what don't I want this to be? It's a great question to ask yourself. And then what do I need information-wise, testing-wise to rule this in or out? And then my clever D5, develop, disclose, document the differential diagnosis. I'll get T-shirts and pass them out next year. Patient education and follow-up, include the patient in the healthcare team. Patients need to know if you think the condition is serious and worsening. You want them on your team. You want them watching for things. Give them written instructions for what to watch for, how to report to you. Always schedule follow-up appointments before the patient leaves the office so that they're in your system. Even if they say, I don't know if I can come, you say, fine, you can change it, but they're in the system. And then your staff should be alerting you if they didn't come. And tracking test results and consults. And again, specific reasons to call before the next appointment. Follow-up systems, 21% of the cases, almost $7.5 million. So again, some resources. We have our non-compliant patients. It has a system for test and appointment tracking, very low tech, way before EMR. Maybe useless if you're Michael Chang or anyone who's caliber using those EMRs. And obviously we have a very specific set of tracking and recommendations for ROP. So from the ordering it through the follow-up discussion with the patient, you have to have a system tracking all this. Always follow up on missed appointments, so you have to have your staff tell you. Scheduling consults for high-risk conditions I already mentioned. Sending the phone contact form to the office after you've spoken to the ER to tell them, there's my second visual, I was wrong, I had two. So that's my really fancy follow-up tracking system. So you don't have to have EMR, but you want to have something on there and keep it on there until you've got the results back, you've discussed it with the patient, and you've determined any follow-up. So this is I'm just excerpting from that document on noncompliance, so this will just, you can even have some chart stamps or something like that to remind you. Sadly, number one, physician competency. Sadly. This was a surprise to me. I did not expect this. 16% of the cases, almost $8 million. You have so much training, but you can't remember everything. And it's getting harder and harder. You have more patients to see. There are more of us pulling on your arms. You've got 25 regulatory agencies now telling you what to do. It's just hard to remember things. So it's really important to come to a conference like this. But again, clinical protocols at the point of care, or if you're one of those gadget people, have them on your gadget. Checklists for complex conditions. Use subspecialists. And then, talking to, if you see patients from colleagues and the care really wasn't adequate, finding a way to try and talk to that person about it, it's still the best thing if it comes from you. But this was, so here are some very modest suggestions, but practice humility. Refer your complicated cases out if you're not an expert. And practice what I call big mind. Those diagnostic processes. What else do I need to know? What am I missing here? It turns out there's a wonderful book on fast thinking and slow thinking. And if you're in that fast brain, it will get you right to the wrong diagnosis really quickly. And so actually, if you do ask those kinds of questions, you're using a different part of your brain, and it actually does improve the accuracy of your diagnostic process. So I'm going to let Bob come back up. We can take questions. You do want to get money for this, I'm sure. If you're an Omic policyholder, turn in your yellow sheet. If you're not, it's helpful for us to know how many come so that we can keep coming to this. So we are welcome. Any questions?
I think Ann did a great job of synthesizing this information, and you can tell what an expert she is. She comes to these medical conferences and listens and takes it all in. And my job, where I finished my spreadsheet, was summarizing each case, taking all the long summaries and summarizing it into a few sentences, and then putting what I thought were the lessons learned. And then Ann took all of that and really synthesized it into these great recommendations here. Let's take some...
If you could go to the microphones for the questions so we don't have to repeat them, that would be helpful.
We'll start over here.
My question is, when you have patients who are chronic no-shows, how do you get them legally out of your practice?
Cyanide. The standard,
especially if they have a significant problem, and they're, so that's a liability to not have them come back.
So my recommendation is that you follow up on everybody who misses things. One call, one letter. A call isn't very helpful under HIPAA, so you send a letter, and the letter, we have sample letters on our website, and it'll prompt you to say, this is your condition, here's the proposed treatment, here's when you need the treatment, and here's what's going to happen if you don't get it or you don't come back for the appointment. And